Good afternoon, everyone, and welcome. Welcome to Healthy Content Matters, bringing patient education online. So here's a snippet of what we'll be covering today. And to be honest, I'm not sure we'll end up using all 50 minutes. So there should be plenty of time for Q&A at the end. So jot down some questions. Thank you everyone for being here. My name is Kristen Gosse, and I live in Longmont, Colorado, which is not too far from Boulder. I live with my husband and 3 kiddos, a dog and a cat, and I describe myself as a writer. I'm an instructional designer. Even more so, I'm a lifelong learner and I'm a brain science nerd. So I'll be getting into a little bit of that in my talk. You'll hear it coming through. My official title is Learning Strategy and Development Manager, and I work for a company called InJoy Health Education. And this is us here on the screen. We're a really small company. We're missing a few people in this picture, but there's only 28 of us. So we get things done very efficiently. And we specialize in patient education materials with a focus on pregnancy, childbirth, postpartum health, baby care, breastfeeding, and parenting. We started as a video company about 28 years ago, and then slowly started adding in print materials like booklets and PowerPoint presentations. And then in probably the last 5 years, started dabbling in developing web apps and e-classes. And needless to say, in the past year, the e-classes have really taken off. And I'm going to touch on that in a few minutes. I've attended this IHA conference several times back in the days when it was in person. I'm sure we're all missing that. And I've always learned so much. So I'm extremely grateful to be here presenting. And just a reminder, this is your time. I'm merely a facilitator here. So please feel like you can be involved. And at the presentation, I'd love to answer any questions you have and hear about your own experiences or challenges. So as I mentioned, over the past few years, InJoy started adding e-classes and webinars to our curriculum. The e-classes weren't quickly adopted by hospitals or other organizations. I think there was this fear that it would reduce in-person class attendance and possibly even impact the jobs of health educators. Our approach all along was to emphasize that adding this option to their education offerings would actually expand their reach into the community. Online learning allowed parents who couldn't attend the traditional in-person childbirth or breastfeeding classes the opportunity to learn the same information as those attending in-person classes. Some families live in remote areas, others work nights and weekends, and let's face it, bed rest is a reality for some pregnant women. But this format gives everyone equal opportunity to learn, and ultimately it can increase patient satisfaction. All that said, it was still a really hard sell. So fast forward to today, a little over a year later, the e-classes are now our best-selling format. We went from face-to-face learning to the virtual classroom practically overnight. And for some, this transition has been challenging, maybe even for some of you, but for many health educators, they're recognizing that making this effort to offer an online option to patients and clients actually shows that you care, you're willing to take that extra step. And obviously, COVID didn't just affect pregnancy, childbirth, breastfeeding, and parenting education. We've seen this transition for things like pre-op and post-op patient education, nutritional counseling, diabetes patient education and treatment, and other prescription plans, etc. As we know, one of the main goals of patient ed is to help people take a more informed and active role in their healthcare, which ideally leads to increased motivation. And motivation is essential for an effective learning experience, whether it's online or in person. So how do you do this? Obviously, it's a big undertaking, and it doesn't just involve well-written content. It requires a little psychology, a dash of behavioral science. But first things first, let's think about the format of your patient ed. To get patients engaged, we need to clear the path, we need to get out of their way, and we need to give them the tools that make the learning easy and, of course, effective. So let's focus on this. The one tool that makes health education easy and effective right now, while we're still kind of emerging from the pandemic, is e-learning. Online patient education has obviously gained popularity, and with more people owning smartphones and tablets, and medical practices are increasingly utilizing digital technologies, we have a population that's just more and more tech savvy, and they're open to applying this to their health and wellness. So how are we using technology in healthcare? We're using it to prepare patients for medical procedures like childbirth. We're administering intake and informed consent paperwork through patient portals. We're educating patients about health conditions. We're providing information about preventative care, encouraging healthy behavior and lifestyle changes. And even insurance companies are using online patient education to inform patients about conditions, procedures, maintenance of chronic conditions, and coverage policies. And then there's our favorite, the self-directed research with Dr. Google, and other things like WebMD, HealthWise, and on and on. So no longer is the physician the sole gatekeeper for medical knowledge. Patients have more and more health information at their fingertips, and they're comfortable using it. It's convenient, and they can access it from home, a place where they feel safe and in control, unlike maybe those face-to-face meetings in a doctor's office where you feel like the doctor is authoritative and they're in control. We're using it for e-health and mobile health in the form of electronic health records, patient portals, telehealth, e-mental health, things like smoking cessation. You've got Quit Coach or Freedom from Smoking. There's websites and online learning applications for gambling addiction, even anxiety. There's a site called Fear Fighter, depression, beating the blues, I Fight Depression, betterhelp.com. There's self-monitoring healthcare devices, such as wearables like the Nike Plus Fuel Band, Apple Watch, and Fitbits. And then there are other monitoring devices that are now connected to technology, things like blood glucose monitors, blood pressure cuffs, and even scales. So literally, healthcare is in the palm of your hand. What are the benefits of this? Well, first of all, convenience. And educating patients with online technology is good for both medical practices and their patients. It gives healthcare providers the opportunity to create comprehensive educational materials that are consistently presented rather than relying on, say, face-to-face meetings where information is presented by a staff member and sometimes inconsistently between staff members. Patients don't have to possess advanced computer or web skills to use this method of learning. A survey of 3,200 patients revealed that even patients who aren't computer literate are still satisfied with online patient education as a means of learning about their medical care. And then there are equity issues to think about. Most people have smartphones now, but not everyone has a computer or internet access. So it's really important that whatever online learning you come up with is also compatible for mobile devices. And you might need to be prepared to have tablets in your office or your facility to approach e-learning from a more equitable place. So we use e-health or mobile health in many ways, but let's just whittle it down to two for our purposes today. And these two terms, synchronous and asynchronous, were fairly unknown to people outside of instructional design. And now they're very familiar, especially if you're a parent with kids in school. We've been hearing it for the past year. We're asynchronous, we're synchronous, we're hybrid. So I think we're all kind of in tune with this language now. And just to kind of recap, asynchronous is typically learning that's self-directed through a website, say in the form of an e-class, a PowerPoint or video, or all three. And it's usually on an app or hosted through a patient portal. The downside is that you have to rely on data to know how effective the learning experience actually was. There's definitely a sense of disconnect. And then we have synchronous, which is basically what we're doing right here. It's educator-led, a virtual class hosted on a platform like WebEx, Zoom, Google Hangouts, or Facebook Live. And even with this, there is a downside. It's hard to tell if your learners are paying attention. Are they bored? Are they confused? Are they learning anything? Are they getting anything out of it? So while these are different types of learning, at the core of both is the content. And well-developed, well-thought-out content is one way to keep your learners engaged, no matter how they are learning, or even if you have that instantaneous feedback from them. And that's obviously one of the benefits when you're teaching face-to-face. You can read your audience. You can adjust as needed. We have those limitations with synchronous and asynchronous learning. So content may include things like PowerPoint slides used in video conferencing software, or e-classes that are made using a learning management system and hosted on a website or patient portal. And they may include content to read, content to watch in the form of videos. They may have games, and they may have quizzes so that you do have a way to assess the learning. But ultimately, the point is content comes in many forms, but whatever form it's in, it needs to be good. And by good, I mean effective. And by effective, I mean it's keeping your learners engaged. They're not just consuming the information, but they're remembering it and they're implementing it into their life and their healthcare. So this word engagement here, you can think about engagement as encompassing empathy, experience, and effect. And in the world of behavior change, these are known as big E, little e, and easy E. So easy E is empathy, and little e is experience, and big E is effect. Your little e is that patient who successfully creates their patient portal or watches the videos you've asked them to watch. This type of engagement is easier to observe and measure. Your big E, effect, is harder to assess from a distance. Is their blood pressure down? Are they taking their meds? Do they understand the difference between the first stage of labor and the second stage of labor? Are they feeling confident about moving forward with the surgery or their birth experience? But if you create content with these goals in mind, right from the onset, you're already halfway there. So let's talk about adult learners, because that's probably who you'll be targeting your materials for. And there are quite a few different adult learning theories, but all of them start with the same basic idea. Adults learn differently than children. Adults tend to be more self-motivated. They understand the value of education, and they often have a solid goal in mind when they start the learning process. They are, and then for children, in contrast, they are actually less naturally motivated in learning situations. Adults, they can tap into their existing knowledge base or their own experiences to understand new concepts, while children are often approaching a new subject from an entirely blank slate. Adults are more able to self-direct and solve problems and learn new concepts, while children have a higher need for direction. Adult learning theories highlight the fact that online health education must be developed with adults in mind to be effective. And there's no one unified adult learning theory, but there are different theories that can fit different needs or different audiences or different topics. So always think about your learner as you're creating your content. This is known as the learner experience, or LX in the tech realm. You might hear that lingo thrown around somewhere, LX or UX. Differences, one is learner experience, one is user experience. Basically the same thing. One of the things almost every adult learner wants to know as they dive into new information is, what's in it for me? And this is typically the elephant in the room. So you need to address it right away. And you can do it casually and create a short list of what they'll learn and why it's important. And the why is just important as the what. So it's the what and the why. Or it can be more formal in the form of learning goals or objectives. So we need to talk about motivation. And I know we're talking a lot about theory, and you were promised more actionable information, but we're getting there, I promise. If someone isn't motivated to learn, they won't learn. And when you think about motivation, you need to think about quality, the source of the motivation, and not necessarily about the quantity. So behavior change design is a discipline that helps create more engaging, effective learning experiences, especially for adults. And motivation is at the heart of behavior change science. And while I find it extremely fascinating, I am certainly not an expert, so I'm just going to touch on it for a moment. Consider this food for thought. And I want to mention it because it's so important to anyone who works on health intervention communication. I can't talk about behavioral science without mentioning one of my favorite books. It's called Engaged by Amy Butcher. She does an amazing job breaking down the different types or qualities of motivation. And this chart is from her book, Controlled Motivation, which is made up of amotivated, external, and introjected motivation. And you're less likely to see the long-term behavior changes or successful long-term health intervention in this realm of controlled motivation. Here, change feels hard, and people are more vulnerable to the obstacles. But with autonomous motivation, this is where long-term change happens, and this is where people reach goals. So you're probably asking yourself, what does this have to do with content? And I'm going to tell you it has everything to do with content. Your content can help make or break motivation. Images have power and words have power. The right words and the right images can help guide a patient or client toward autonomous motivation. And that's where you want them. So choose your words and images wisely. So the next thing I want to talk about is human-centered design. And the words and images I just mentioned, those are human connection in digital health technology. That's how you connect with the human holding their iPad or their phone, learning about childbirth, their upcoming surgery, or how to lower their blood pressure. Behavior change and learning starts with true human connection, right? So how is it possible to bring that element into technology? Well, human-centered design is one way, and it's exactly what it sounds like. It's design focused on the human. And as a general process, it helps us identify people's needs and innovate ways to meet, alleviate, or even preempt these needs. And applied to science communication, it challenges us to ask who our audience really is. We need to learn what makes them tick and acknowledge where their interests, attitudes, perceptions, and biases interact or stray from our own in order to make our communication even more meaningful. And then this particular human-centered design strategy was created by the brilliant Jen Briselli, and I love it because it's specific to science communication. And if you don't know who Jen Briselli is, she's an expert on behavior change and the VP of Experience Design at MadPow, which is a company based outside of Boston, and they specialize in product development with a focus on behavior change. In fact, I've included some of Jen's really cool PDF resources as part of this presentation, so you could download those. And if you can't find them, feel free to email me and I can send them to you. So I want to go through her strategy, and I'll do that in the next few slides. The first one to talk about is self-reflection. And in this case, self-reflection is about understanding how your own values influence your communication. Even when scientists aim to communicate purely scientific information with objectivity, their personal values influence the message and its interpretation. Your self-reflection influences choices, whether it's deliberate or not. And this comes through in your tone, in your voice, in your narrative style, with metaphors and visuals. These things all frame information, and sometimes it's subtle, and sometimes it's incredibly powerful. And then there's awareness of your own tendencies. That's the critical first step in the process of communicating more effectively. And what do I mean by that? So one way to think about it is, what are your attitudes toward controversial or politically polarized topics? Who do you find yourself most likely to argue or debate with at family gatherings or parties? And it's thinking about these things that can unconsciously influence your communication. So being aware is really important. That's a critical first step as you're thinking about how to present the information you want to share with patients or clients. And the next thing is empathy. And you need to understand how your audience's values influence their own perceptions. And this is about walking in someone else's shoes. And this kind of understanding is crucial for effective, powerful communication. More than age, gender, education, or even political meaning, a person's values and worldview influences how they interpret information, especially when it comes to health-related or risk-related information. If our message is to be meaningful, we have to meet our audience where they are right now. So you might want to think about, how might you approach a particular topic differently if you held a different set of values, or if your audience holds a different set of values? And maybe consider a bit of role playing here. Next time you're preparing to write or speak to others on a particular topic, pretend you're operating from a different worldview. How does that change things? Next up, we have identity affirmation. So what does this mean? This means framing information that affirms values. We may aim to change things like attitude or perceptions, or maybe even change minds. But we have to leave the challenge of changing values, which is a far more daunting task, for another time. So you need to design your learning experience or your communication to allow for slightly different interpretations, so that people with different worldviews can reach conclusions that affirm their values. So here's a timely example. Vaccine messaging. It tends to focus on community responsibility and all the benefits for the community. But that frame isn't going to resonate with someone who has, say, strong individualist values. In their mind, they may find the potential risks to a community of nameless, faceless strangers irrelevant. So instead of challenging or arguing with or condescending to this person or these people, why not include messaging that also provides an individualist frame? such as emphasizing the personal benefits of vaccination for them. So ask yourself, how are you framing this message? Will it resonate with someone with individualist views? And then avoiding threats or a non-threatening message. You need to be deliberate in avoiding threatening language and value judgments. Sometimes it's not practical to affirm all the various cultural worldviews in a single message. Depending on the circumstances and the nature of the message, it may be less relevant or too difficult or maybe even problematic to incorporate affirmative themes for multiple values. However, it's crucial at the very least to avoid threatening or alienating specific worldviews, which can contribute to polarization on a given topic. So becoming a little more mindful of the way the information is framed and how certain judgments may threaten a particular worldview, we can communicate to a wider audience more effectively. And an example I like to use for this is something I'm very familiar with. So consider breastfeeding education. Not everyone is successful at breastfeeding. And I've seen material that's so polarized to pro breastfeeding, it actually adds to the stress and guilt new moms have when they're experiencing challenges. They read things like, if you don't breastfeed, your baby won't be as healthy. They may grow up to be obese, or they may be diagnosed with diabetes. No new mom needs this message. Make the message feel supportive. So I would say, think about these things as you're creating your content. Are you avoiding threatening or alienating a specific worldview? And again, being mindful of how that information is framed and how certain judgments may threaten particular worldviews. Next up, we have pluralistic advocacy. And that's where we're drawing support from diverse sources and cultural worldviews. And people tend to assign greater credibility to experts who share their own values. And because of this, people are less likely to become polarized on a topic when they observe trustworthy people who share their values. And that's advocating from some unexpected positions. And the COVID vaccine is another example of this. Say there's somebody who is adamantly against getting the vaccine. You know, they've heard it might have long-term health effects or cause sterilization or some of the other myths we've heard connected to the vaccine. But then they have a friend who was also against getting the vaccine and they've changed their mind. They decide to get it. They have no side effects. So far, the myths don't seem to be coming to fruition. And that person may now be more influenced to change their point of view. So it's important to call in experts with diverse values so that you can advocate various positions in your message. You can find quotes or evidence from sources across various cultural worldviews. You can explore different examples, different metaphors. You can even have some short little story vignettes that can provide a wide range of interpretations. Emotional resonance. So on that line of short story vignettes, it's telling a story is so meaningful for so many people. They can connect to it. And this is because when information is shared in a compelling narrative form, one that uses vivid metaphors, not only are the language processing parts of the brain activated, but other areas of the brain that we use when experiencing the events of the story are also engaged. So studies show that people actually remember facts told in the context of a story better than any other form. In other words, your message will be far more meaningful, and by that I mean entertaining, persuasive, or informational if you engage with the audience in an emotionally resonant way. So use those powerful images, use language, and use narrative structure to your benefit. And You'll engage with the audience in an emotionally resonant way. You'll be entertaining, you'll be persuading, and you'll be informing. All right, so here's the nitty-gritty. What is healthy content? And healthy content happens when you know your learner. You've identified their needs and gaps. You know what they want. And I can tell you one thing, nobody wants to feel stupid. So keep that in mind. You want to help them understand, and you want to keep them engaged. And to keep people engaged, you need the right amount of content. And I love this quote here: respect your learners for they are not you. And Julie Dirksen, the author of Design for How People Learn, she has that in her book, and I just feel like that's so true. It's not about us when we're creating this material. It's about the end user. It's about the learner. It's about the patient. It's about the new mom or the new dad or the family that's about to have a baby. So that's the most important thing to keep in mind. But on the topic of what's the right amount of content, and it might be hard to read this, but I'm going to say this first. The right amount of content is probably way less than you think it is. Working memory has a limited capacity, so communicating more content than your learner can take in is a total waste of your time and theirs. And I love this image. This is also from Julie Dirksen's book, and basically it illustrates that you can keep handing material to your learner, but you can't make them carry it around. You need to examine what it is you want to communicate and focus on what is most relevant to the learner, not you. So ask yourself, what is necessary, and can anything else become a resource to give them later? Focus on what's most important. And Julie's advice just sticks with me as far as this message. And she says that it's helpful to start lean with your content and then test it along the way with your learners to see where the holes are. If it's not enough, you'll know that pretty quickly because they'll be confused and they'll have questions. And then starting with too much actually makes it harder to identify what's truly needed. It's harder to cut after the fact than it is to add. So how do you keep them engaged? Even using technology, you have an opportunity to create content that entertains, asks questions, you can change the learning up, and you can provide opportunities for interactions and activities. And I showed you examples of that in the beginning of this presentation with some of the games. You can create spaces for reflection, quizzes. That's all a great way to get your learners to be engaged. Content that entertains appeals to emotions, and emotions help with engagement and memory. We talked about that in the form of stories and narratives. And include questions that ask contents, and even if that ask questions. And even if you don't hear the response, your learner will think about those questions and perhaps they'll answer it on their own. And this is a huge part of the autonomous motivation we talked about earlier. When you change it up, you're appealing to different learning preferences by using a multimodal approach. So ask yourself, can you include videos? Can you include infographics? And finally, include content that encourages that interaction, even if it's just interactions between the learner and the content. All right, so here are 5 tips to write healthy content. And first of all, I've said this several times, know your audience, know your learner. List and prioritize the top tasks that learner needs to know. List what people need to actually complete the task you're asking of them. And list characteristics of the groups that can influence your content. For example, think about ages, reading levels, computer experience. Delve into the demographics a little bit. The audience definition works when you know who you are and who you are not designing for, and what they want to do and what they know and what they need to learn. The second tip is structure your content to guide the reader through it. Organize the content so it flows logically and smoothly. Break content into short sections that reflect natural stopping points. Write headings that help your readers or learners predict what's coming next. The structure works when your learners or patients or clients can quickly and confidently find the information that they're looking for. And use plain language. This is health literacy. We know this. A communication is in plain language if its wording, its structure, and its design are so clear that the intended end users can easily find what they need, understand what they find, and use that information. They can apply it into their life. Keep it short and to the point. Write short and logical sentences. Include details that help your learner complete the task. Leave out the details that don't help or that might distract, even if they're interesting and important to you. Set a helpful tone, a supportive tone, and make it conversational rather than a legal or bureaucratic tone, and pick the right words. Use words that your audience knows. Make titles or list elements parallel. For example, if you have a bullet list or even a numbered list, start each with a verb. The language works when readers understand the words and grasp the intended message quickly and confidently. Use information design to help readers see and understand. Use headers and subheaders to organize the information. Use typography to your advantage. Think about the font size, the color, is it bold, etc. That can help guide your learner's attention. Use white space. White space is your friend. White space is your learner's friend to organize the information. It allows the brain to pause and take a breath and internalize what is being learned. Use images to make content easier to understand, and make sure they're inclusive and diverse. Think about your entire audience. The design works when your learner notices and uses the signposts throughout the content to move more efficiently. And then work with your target user groups to test the design and content. I call it testing and tweaking. It's never completely done, and that's the beauty of digital applications. You're not investing a lot into something that goes to print. You can quickly jump into your learning management system or your content management system or whatever back-end software you're using and change things. Be open to changing it. Listen to the people who are using your materials and take their feedback to heart. Test it at different points in the process. You don't have to wait till you're completely done. You can make sure your test participants are representative of the target groups. That's really important. If you're not targeting the right demographic, then you might not be getting the feedback you need. You want to check once you have a final product that it's useful and usable. And this comes back to that user experience. You can ask your learners to describe who and what the document or the site are intended for. Have them show you how they would find the information they want or need. And then have them teach back. Ask them to describe the key concepts or processes in their own words. And just a quick note, I know when people hear testing and focus groups, it sounds really intimidating, but honestly, you can get useful information when you're testing with even 2 or 3 people. Any feedback is better than none. Even if it's one person, it's still feedback you're getting from an end user. So I would say 3 is a good number to shoot for, 3 to 5, but you don't have to think about this huge time-consuming focus group. And then think about content in the form of fuel or fiction. And I got this graphic from a behavioral scientist with Pattern Health. Her name is Aline Holsworth. And this is where health literacy and behavior change intersect. So consider this theory of fuel versus friction. Sorry. Research tells us that the harder something is, or the more demand we make on cognitive load, the less motivated your patient or client will be. So that's what friction is. Friction is content that doesn't support health literacy. It uses medical jargon. It's hard to understand. It's cumbersome. The goals are too lofty. So make your content as pain-free as possible. Let it be the fuel. Remove the barriers that could cause frustration and set your patients and clients up to succeed. Make it a delightful experience without the obstacles that makes people want to start and keep using your material and makes them want to make the changes that they need to make to have a healthy lifestyle or a successful birth, or do well in parenting or have a successful surgery. Let your content be the fuel behind the learning. And that brings us to the end. Thank you. And do we have any questions? Okay, let's see. We've got some questions here. Give me 1 second to go through. Let's see. Amy asked, as you presented, there are a lot of options for people to use to educate themselves about different healthcare issues, but there's a lot of bad information out there. How can we help people, especially those who may not be technologically literate or comfortable, critically look at the information to ensure it's as accurate or that it's false? And that's where I think there's a huge benefit of creating your own online learning materials, because one way to sell them to your end user, your patient, or your client is that it's credible, it's accurate. They don't need to go down that rabbit hole of the internet where there is a lot of inaccurate or dated information. And I can say personally at InJoy Health Education, that's how we market a lot of our curriculum, is that we've removed that question of, is this credible, accurate information? You know, we've already made sure it's research based. I think there's a lot of bad information out there, and I think one way, when you're in control of that information and you're sharing it with patients or clients, that's one way to kind of steer them in the right direction. Let's see. And then Sarah also had a question. How do we create effective health education when we have many different people viewing it? Yes, different life experiences and different worldviews. Yeah, you don't know who your end user is when you're creating something digital. You don't have that benefit of sitting with them face to face. So one of the things I do kind of at the onset of creating my learning materials is I look at demographics. We go through the process of doing a needs assessment, and we're lucky that our materials are sold through hospitals. So I can talk to health educators. And in the case of what we do, it'd be childbirth educators or postpartum discharge educators. And they can kind of fill those blanks for us. They can tell us about their patients. And we kind of create these patient identities to work from. Really inclusive and diverse content is important. You need to make sure your images are diverse and inclusive, and you need to make sure the language you are using is diverse and inclusive. And we've just recently switched to using gender neutral language in our materials in an effort to be inclusive. We got feedback that people felt like it wasn't inclusive enough. So, I would say you just kind of need to get it out there, and then you'll get feedback and you'll know whether or not it's hitting the mark. But there are some things you can do at the onset of kind of planning your digital learning materials. See, Julie asked, I'm the content specialist for a large digital medicine program in New Orleans. We've been recently using more animated images and videos than real pictures. Do you think real pictures are more impactful, or do you think animated can be just as relatable? Oh, great question. At InJoy, we tend to use all real video footage. We film real families, they aren't actors. And then we usually pull our stills from the video footage. So real people, they're not glossy and shiny. I think it's important to have a balance of both. And in our print materials, we do that. We do use some stock images in there, especially like where we have gaps or we can't get certain things. I think there is a place for animation. I'm thinking about how we present, say, like the epidural procedure. Not many people really want to see that live and in person, or even a cesarean is another great example. That's a little too graphic for most people, and that's where animation can be a real lifesaver. We also use it to illustrate the effects of shaken baby syndrome or abusive head trauma. You can't show that in a photo. So I think animation certainly has its place, but real pictures and real videos also are incredibly relatable to your audience. Though you may get feedback, and I'm speaking from experience, I know we've had feedback from some hospitals saying that they feel like our real images aren't glossy enough, and they're not pretty enough for whatever. So yeah, it's a delicate balance. You might have to be educating some of your end users about why you made those choices to use real images and real video, or why you've opted to have animation for something instead of an actual video. Let's see. This looks like I got cut a little, but let me try to interpret what it says. It's only self-paced PowerPoints with video links. I felt like not having a health educator to speak with and ask questions was very detrimental to the effectiveness of the course. That's a really good point. And I think for some people, this style of learning works great for them. For others, not so much. I think what we're going to be seeing in the future, in the very near future, is more of a blended learning approach, where you're going to have maybe some online asynchronous learning, maybe some videos to watch, or a short little e-learning module. And then there's an opportunity for learners to get together in a virtual space like Zoom or WebEx, where they can ask the educator questions. I think there's also going to be some movement towards more virtual classrooms, which will kind of have like a hybrid approach. So in the virtual classrooms, they'll be watching videos, or maybe doing surveys together or polls. So I think what we're finding is that having a blend of both is really supportive in the learning process. But there are certainly some people who do just fine learning on their own. They really thrive in that self-directed learning atmosphere, but it doesn't work for everyone. I think it's always good when you can have a real person at the end of a self-directed learning experience that you can ask questions to. So I would say, even if you're creating like a pre-op process that is asynchronous or self-directed, that there is a point person, a real person that that patient can talk to after they've gone through the material and have their questions answered. Say, Chelsea asks, I love the idea of using real examples, relatable influencers, etc. Is this feasible for creating deliverable content that's intended to be used for the masses? Will it hit home for everyone? No, it probably won't hit home for everyone, but I just, do your best trying to be creating diverse experiences. Really focus on that inclusivity. Think that's where you got to think outside your own worldview and think about where other people are coming from. Otherwise, you really will be dealing with some limitations there. Let's see. What kind of general education threshold do you assume? Is that 7? Not sure I understand that question. I'm sorry. How often, if at all, do you have patients provide feedback on how they prefer to learn, receive, view information, etc.? If at all, how has this been done during the pandemic while most patients are learning at a distance? Well, I can only speak for how we're doing it at InJoy. We have polls built into our e-learning where, we use the polls for kind of 2 reasons. One is to create a social learning aspect, because after somebody answers a poll, it pops up the results of other people who have answered that poll. So our goal is to try to make people not feel so lonely as they're taking this asynchronous class. They can see that other people have taken it, they can see their answers, but it also gives us a gauge for how they're learning this information or where they're at. We also have a pre-class assessment and a post-class assessment that measures learning transfer in the process of that learning experience. And we can see how far they've come from the beginning of the class to the end of the class. It's not a perfect science. I mean, it's 3 questions. It's the Likert scale. It's really just some simple raw data, but it's enough to kind of give us a feel for what they're getting out of it. If they've been engaged, they make it to the end of the class, and did they take that post-class assessment? And then a lot of times, some of our hospitals are now implementing that blended strategy. So we have the learners go through the e-class, and then they meet with the health educator and they give feedback. We do get a lot of feedback from our educators about what's working and what's not working. So they're really kind of our portal to the end user. And they're very vocal and very willing to share people's experiences, the good, the bad, and the ugly. So we're constantly looking at ways to improve things. There's multiple iterations of these digital learning experiences. They're never done. They're constantly evolving. The end users are constantly evolving. We've gone through millennials as new parents, and now we're starting to venture into Gen Z, and these are people who have been learning and using digital technology their whole lives. So things are going to keep changing, and you have to be willing to constantly adapt and evolve along with them. Let's see. Jordan asks, what software or resources do you use when creating e-learning content, including infographics and for evaluation and analytics? How do you design effective training with minimal demographic information and no ability to improve upon the data you've received? I think we kind of covered that part, but to talk about software or resources to create e-learning content, I use a learning management system, an LMS, called Thought Industries, but there are a ton out there. And there are some that cost a lot of money. There's things like Captivate or Articulate. And then there's some that are actually free. Moodle is one that it's free. It's a very basic form of Moodle. They do have some more sophisticated ones that you can pay subscriptions on. But even the free Moodle is really powerful and really easy to use. And it does have some built-in analytics for you. I've only used it once or twice and just for fun, kind of messing around. So I would suggest checking out Moodle if you want to try a free software and see if it works for you. And then there are all sorts of places you can go to create your infographics. One that I use is called Genially, and it's GENIALY.com. And again, they have two options. There's a free version, there's a subscription-based version that's a lot more robust. But the free version, you can create these really cool infographics, some animated infographics. You can create games and interactions. It's just a really cool software. So I would recommend checking that out. Let's see, we have a few more here. We've got about 4 minutes. All right, what platforms do you use or recommend? We just kind of talked about that. Let's see, what are the 2 best books that you'd recommend to guide different types of educational material and development? Well, the first one I would recommend is Engaged by Amy Butcher. And while that has a heavy focus on behavioral science, it's really applicable to health education. And in fact, Amy does a lot of health education materials. So she does bring that into the writing, and it's really a great book that gives you information that you can apply right away. And then Julie Dirksen, her book, Designed for How People Learn, is really great. And while that one's not necessarily focused on the healthcare industry, it's just written so well and uses these amazing graphics to kind of walk you through the information. And it's super easy to absorb and apply, lots of actionable information. There's so many other books, but I would say those 2 are my top favorites right now. Oh, here's a good one. This is very relevant. We have 2 minutes. Sometimes writing in gender-neutral language around pregnancy topics may sound weird or inaccurate. Example, breast congestion when talking about breastfeeding, chest feeding. We prefer to use the term breast, even non-inclusive, but because it's medically accurate. Any feedback? Well, I totally agree. It's incredibly challenging. I've been in the process of turning all of our materials, print materials, video scripts, and e-classes and web apps gender neutral. We kind of started slowly where we made the baby gender neutral. We used to do alternating he, she. So on one page it would be he, the next page we'd say she, and then it just turned out to be a nightmare because we'd go in and change content as things got updated and we'd forget what gender we were on. And so you'd have a page where or a sentence where it started out talking about a male baby, and by the end of the sentence it had changed to a female baby. So we were just creating all sorts of chaos in our material. So we just decided to make everything gender neutral. Everything's they, their, them. There's certain topics where we're not doing that. We have a grandparenting class where we, it's hard to reference them when you're talking about mom to a grandparent, or a sibling preparation class. How do you do that with children and using the term there? So in those cases we stuck with the more traditional verbiage and genders. We haven't, those are just going to market, so I'm anticipating we will get feedback that we may need to change it, and we'll tackle that then. But everything else, childbirth, breastfeeding, postpartum education is now gender neutral. It was a huge challenge, but one of the ways I overcame that is that I focused on the end user. I used you a lot, like I was talking to them. So you, yours, that kind of helped me get around it. It was a little more difficult with things like partner tips, but I just kind of made that shift to referring to mom as the pregnant person or the breastfeeding person or the person in labor. I don't love how it sounds, but I think as we move through the years here and Gen Z comes of age, they are really used to a gender neutral language. So I think it'll get easier, but it is a challenge for sure. But I think it's worth the effort, and people appreciate that we're making the effort. All right, I think time's up and we're done here. If anyone has any additional questions, please feel free to email me. Thank you. Have a great day.